I'd like to talk to you initially about the background of Pregmedic, discuss the current situation as we see it in Canada with respect to medications in pregnancy and lactation, discuss briefly what's happening in some other countries and where we think we need to go. Pregmedic was formerly called CaseMed Pregnancy, which stood for the Canadian Alliance for Safe and Effective Medication during Pregnancy and Lactation. So you can see why we changed the name, because it was such a mouthful. But it arose out of a conference, again, under the auspices of the Canadian Society of Pharmacology and Therapeutics 4 years ago on May 10th in 2006, at which time there was a discussion regarding establishing benchmarks for drug evaluation during pregnancy. There was a consensus that arose out of that symposium that there was a need for collection and analysis of data on fetal safety and ongoing post-marketing surveillance. The symposium proceedings were published in the Canadian Journal of Clinical Pharmacology, and to them we are very grateful. The mission of Pregmedic is to advocate for the safe and effective use of medications in pregnancy and lactation. And as any good group has, they have some goals that they want to achieve, and we would like to increase the awareness of pregnancy issues with respect to Health Canada and with Canadian practitioners. The Canadian practitioners, of course, include obstetricians and gynecologists like myself, family physicians, nurse practitioners, midwives, public health nurses, and pharmacists who are assuming a larger role in health care with respect to our patients. We would like to see standard labeling of medicines for use in pregnancy and lactation. This would provide practitioners and patients with access to current and reliable information for decision making. And we'd like to advocate for the development of patient registries and surveillance programs for medications used during pregnancy and also used during breastfeeding. There are certainly medications that are used immediately prior to pregnancy. They're also important as well. During pregnancy, there are some changes in total body weight and body fat. Delayed gastric emptying and prolonged GI transit occurs, which can alter absorption of orally administered medications. There's increased extracellular fluid and total body water, which also will change distribution of medications in the body. Increased cardiac output occurs, largely because of an increased stroke volume and an increased heart rate. Decreased albumin concentration with reduced protein binding alters the effectiveness of medications in some cases. Increased blood flow to organs, specifically the kidneys, will result in glomerular filtration rate increases, which could lead to increased clearance of medications, and changes in hepatic enzyme activity also will alter the effectiveness of medications and their metabolites. There's no question that many drugs are used in pregnancy and lactation to treat chronic and pregnancy-induced conditions such as hypertension, which will occur prior to pregnancy, can occur during pregnancy de novo, or can be exacerbated by pregnancy. And there are very few drugs that are studied for use during pregnancy and lactation, and little guidance is available to healthcare providers. Most product monographs advise that drugs should not be used during pregnancy and breastfeeding. And for many reasons, cost, litigation, pharmaceutical companies do not address pregnancy. Information is usually obtained post-approval, and adverse drug reactions are reported voluntarily. And most medications, in fact, are used off-label in pregnancy. There are some pregnancy exposure registries. There are some retrospective birth defect registries. But these are hard to access. This information does not seem to be widely disseminated or publicized, and it doesn't seem to be in one place or one repository where we can gain access to this information and then provide it to practitioners and patients. So healthcare professionals are left with the burden of evaluating the risk-benefit of using a medication during pregnancy and breastfeeding. And I quote from an article in the American College of Obstetrics and Gynecology that indicates that many labels are outdated, and 2 recent randomized controlled trials examine outcomes in pregnant women exposed to metformin with numerous clinically relevant endpoints, and the information would help inform clinician prescribing and patient counseling. However, the metformin label contains data from neither of these studies, and regulations do not require manufacturers to include post-marketing published data on the drug monographs. And for an individual clinician, searching and reviewing the medical literature is labor-intensive, not always feasible, and requires an ability to discern a study's quality and power to detect risks. That is a difficult task for individuals talking to a patient in the office about what medications they should take or shouldn't take in pregnancy. So we'd like to examine what's happening in other countries. And the FDA in the past has required labeling according to preset categories, and most drugs are labeled pregnancy category C. And these are the ones that are used for labeling. And one can assume that A is the safest and X is the most worrisome. But again, from this article, the letter categories are limited in their scope and misunderstood at worst. The current system is not a gradation of risk from A to X in the category, in which category C, for example, affords less risk than category D. In fact, category C, D, and X are based on risk weighed against benefit, and oral contraceptives are labeled X, not because they are inherently riskier than category C, but because they afford no benefit during pregnancy. So that there is a move to change these categories, and on May 28, 2008, the FDA proposed to amend its regulations for labeling and to move pregnancy information from the contraindication section to the section use in specific populations. And prescription drug labeling would require pregnancy exposure registry information, a general statement about the background of the risk of fetal development abnormalities, clinical considerations, and a data component. Very recently, and we will have somebody speak to us about that later today, the FDA announced that it will collaborate with other researchers in a new study called the Medication Exposure in Pregnancy Risk Evaluation Program. And information will be gleaned from 11 health plan affiliated research sites, and we are expecting great things from this study. It's interesting that 2/3 of women who deliver have taken at least one prescription medication during pregnancy. Many more have taken non-prescription medications, and also 45 or 50% of pregnancies are unintended in North America, not necessarily unwelcome, but unintended, and so many women are on medications prior to conceiving and not know that they're pregnant. In Europe, the European Medicines Agency evaluation has a guideline on the exposure to medicinal products during pregnancy, and have identified a need for post-authorization data. There's a guideline on risk assessment of medicinal products, and this is labeled From Data to Labeling, effective January 2009. And the European Medicines Agency has developed examples of statements that we can hang our hat on as clinicians or practitioners that allow us to counsel patients and provide them with knowledgeable information so that they can make a decision. And some of these are on the screen here based on human experience, and they have to specify exactly what that human experience is. A drug is suspected to cause congenital malformations. The nature of those should also be specified when administered during pregnancy. And it should not be used during pregnancy, and the trimester should be specified unless the clinical condition of the woman requires the treatment. These kinds of statements are quite explicit, and there are a number of those that we feel are valuable in helping us counsel patients with respect to risks and benefits of medications during pregnancy. And this is a bit of a complex slide, but it shows a scheme to develop a recommendation against a medication in pregnancy. And it largely, on the left-hand side, looks at human experience and whether or not there's sufficient data from clinical assessments, and if not, it moves to the non-clinical areas and helps shape the type of recommendation that could be made. So, Pregmedic priorities are to draft a guideline for inclusion of pregnant women in pharmacokinetic studies, and this was presented to Health Canada in June of 2009. We advocate for the adoption of European labeling requirements for pregnancy, and are requesting creation of registries for women who need to take drugs during pregnancy, and also for post-marketing surveillance. We are pleased that we have been able to work with the Society of Obstetricians and Gynaecologists and are in the process of developing a policy statement and hopefully some education pamphlets, not only for patients but for practitioners who are caring for pregnant or nursing women. Our intent is to undertake some presentations at CME events, for example, with respect to natural health products, and also with things that are taken for granted, vitamins, for example, and the value of these for adolescent women, women determining whether or not they're going to get pregnant, and during pregnancy and lactation. We are very pleased to be associated with Mother Risk and, of course, the Canadian Society of Pharmacology and Therapeutics. These are speakers today, and I would like not to delay the introduction of them, but would be pleased to answer any questions that you might have. I'd like to take this opportunity to introduce Dr. Bob Davis, my handsome nephew, no relation actually. He is the director of Center for Health Research Southeast from the Kaiser Permanente of Georgia, and is a lead researcher in the new research program called the Medication Exposure and Pregnancy Risk Evaluation Program, which I alluded to earlier. And this is to study the effects of prescription medications used during pregnancy, and we'd like to thank him for coming all this way and welcome him to Canada.